I think we'll start. Good day and welcome to this Smarter Health Seminar. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today for this seminar. I'd like to welcome our over 60 web viewers and the Ontario Telehealth Network sites. This seminar is being recorded and is being broadcast over the web. We ask that you hold your questions to after the seminar presentation so that we can get a real or virtual mic to you. A very warm welcome to our guest speaker, Gail Crook. I will introduce Gail more fully in a moment. These seminars are hosted by the Waterloo Institute for Health Informatics Research, the Lawson Health Research Institute, and the National Institute for Health Informatics. I'd like to acknowledge our seminar series sponsors, Borden Landner Gervais, McKesson, and Healthcare Information Management and Communications Canada. Without their support, we could not hold these seminars. I have a couple of announcements. Our next Smarter Health Seminar will be on Wednesday, April 22nd. Our guest speaker will be Neil Gardner, who is the CIO, Health Information Solutions Centre for the Saskatchewan Government, and he's also on the board of COACH. As well, we're offering 2 health informatics boot camps. From May 6th to 8th, there is a health informatics boot camp for HIM professionals at the University of Ontario Institute of Technology. This boot camp is designed exclusively for HIM professionals and is being co-hosted by CHIMA and UOIT. Our regular health informatics boot camp will be held here at the University of Waterloo from June 17th to the 19th. We're also holding eHealth risk workshops in security, privacy, and risk management from April 13th to the 16th here at the University of Waterloo. You can register for all of these events on our website, hi.uwaterloo.ca. The Smarter Health Seminars this year is focused on health informatics and the eHealth industry. The schedule for today is as follows. Gail will speak for 45 to 50 minutes. This will be followed by a facilitated discussion. We ask that you hold your questions, as I said before, to after her presentation. Please signal that you have a question and we'll get a mic to you. We invite our web and teleconference viewers to please send in their questions. It is my pleasure to introduce Gail Crook. Last month, we learned about the state of the eHealth industry from Brendan Seaton, president of iTac Health. Who better to follow Brendan than Gail Crook, who is CEO and Register of the Canadian Health Information Management Association. She'll be speaking on the crucial role of HIM professionals on the eHealth team. It has been my pleasure to know Gail for some years now. Gail Crook became the Chief Executive Officer and Registrar for CHIMA in March 2001. Prior to this, she worked for over 25 years in the acute care sector as Director of Health Records and Utilization Management. She's also managed 2 family medical centers in London and was the manager for integrated strategic alliances and networks for the London, Ontario hospitals. Gail has an extensive background in case mix group methodology, case costing initiatives, privacy and security of patient records, the collection, dissemination, and quality of health information, and work experiences regarding the transition to the electronic health record. She has published and presented both nationally and internationally on all of these subjects. I am most interested in hearing Gail's presentation today. Please give a warm welcome to Gail Crook.
Well, hello to everyone. I'm glad to see that I do have an audience. Sometimes it's a little unnerving when you're doing webcasts or telehealth. You never really know who you're talking to. So I know we have a lot of virtual listeners, but it's nice to see some warm, friendly faces that I can also just gauge how my presentation is going. So thank you for being here, and thank you very much to the hosts for asking me to speak. The subject, the crucial role of the HIM professional on the eHealth team is something that I am involved in very, very deeply day to day, and don't always get the time, really to come out of our settings to have a discussion and, bring new thoughts and new ideas. So I truly do appreciate this opportunity. I am, because it is, I have a virtual audience as well, I'm going to be utilizing, I'll be ad-libbing some of my overheads, but I do have speaker notes, and it's just because there are a couple of points I really don't want to forget to make. So I'll do a little bit of combination there. My outline today, I'm going to give you a bit of an overview. I know that there are a lot of HIM professionals virtually and a couple here in the audience, but it doesn't hurt to just reiterate our profession and who we are, what we do. I'm going to talk a bit about, and that's what you've asked me to talk about, the health record within the eHealth environment, some of the challenges for the electronic health records, and there are a lot. I'm only going to touch on a few, but there certainly are many more. What the HIM professional brings to eHealth. Then CHIMA has gone through in the last 18 months, and I'm going to spend a little bit of time talking about the long-range scenario planning process that the organization and the college has gone through. We have just really completed this formal long-range scenario planning process. The board have made some very strategic decisions on our pathway, a roadmap for the HIM professional. And really it's, while some of our members have heard bits and pieces of where we're going with the roadmap, this is probably my first opportunity to really articulate that in a much broader audience. So I'm glad I have an opportunity to do that. And then some of the strategies that CHIMA has used and is using to ensure the success of the HIM professional in the eHealth environment, and then some lessons learned. So a little bit about CHIMA. We are actually the acronym, and some people, I think I was the last holdout on the acronym CHIMA, but I see that even AHIMA have gone to saying AHIMA instead of AHIMA, so I may go back and forth. It means the same thing if I say CHIMA or CHIMA. But CHIMA and the college, which is the Canadian College of Health Information Management, are both registered associations with Industry Canada, and we have a long, long history. We have just 2 years ago reached our 65th year, so certainly the association and the college have been around for a long time. We have about 4,500 members. Our members certainly right across the country. I will talk a little bit about certification and mandatory education, but basically there probably are 5,000 and 6,000 HIM professionals across the country. In Canada, we are not a regulated profession, so it is not mandatory in some provinces to be certified. So while I sometimes say we have 5,000 or 6,000, they are HIM professionals that we know are out in the field, but not all of them are active members of CHIMA. We mostly work in the acute care settings. So that would be I would say every hospital in Canada does have a health record or health information management department that employs clerical staff. That would be the staff that are responsible for ensuring the components of the record are available when they need to be available. Transcription. The transcription area is traditionally found within the health records department. Coding, the coding classification for international classification of diseases would be found within a traditional health records department, and quite often just de facto because of our linkages with privacy, the director of health records or one of their supervisors might also be the chief privacy officer. Also, some areas like decision support might be within a health records department, but we are seeing new models where that work is aligning more closely either with planning or with finance. So I will talk about, when I talk about challenges, some of this shifting landscape and how that affects the current way we all do business and how we're going to be doing it in the future. My age, I'm going to have to put my glasses on just to have a quick look here. This really is a very exciting time for CHIMA. We feel it is, the board feels it is, mainly because of the changes, the opportunities that the eHealth environment affords our members. And while a great deal, or maybe a third of our members, might be the traditional, what we call people who code by the ICD-10, we do know as the electronic health record matures that sometime we will see probably auto coding, and those jobs the traditional way we do them may go in a bit of a different format, but that gives us the opportunity then to transition our members with new skill sets. Our mission, and this has been our mission for many years, we are professionals who contribute to health and wellness by leading, promoting, and ensuring excellence in information and knowledge management. And the vision is to be innovative leaders in health information management. CHIMA, the association, has 4 strategic directions, and really this is the business of the association. This is the work that the Board of Directors and the Council on Education ensure that we do. The first being provide education standards and certification. So the college is a registered college with Industry Canada, and so the work around education standards is to ensure that new programs or even existing programs go through a process of recognition so that we ensure that they're teaching the learning outcomes for health information management programs. We also ensure certification of our members, so a graduate of a certified program then would challenge the national examination and have certification. And as well, we would ensure that programs, even who have been in the business for a long time, would go through a re-recognition process. I do believe that's every 6 years to ensure that they have kept up to date on their curriculum as far as some of the learning outcomes that we expect them to teach. The college or the council also is tasked with developing the examination, and CHIMA offers the examination twice a year. And so the exam subcommittee meets quite often through the year to develop new questions, review the questions, and ensure that the exam is ready for that twice a year. And then we have a continuing professional education committee, which ensures that we have materials such as this, that we would be offering NIHIMs, continuing professional education credits for this type of session as it's a learning session, and that committee sets what constitutes or what criteria is needed for a CPE. The portfolio promote health information management expertise. This is all about the work of the board ensuring strategic alliances with key stakeholders. And that would include our board executive and myself would meet quarterly with senior management from Canada Health Infoway, from the Canadian Institute for Health Information, with other like organizations like COACH, just to ensure that we are working together, that we're really in tune with the work that each of us are doing and are complementary to each other as opposed to going off on our own. We also, within that portfolio, support a lot of our members to belong to the Infoway Standards Collaborative Working Groups. So there are about 9 working groups, and I'll talk a little bit more about that later when I talk about standards. So that relationship with Infoway is to ensure that the HIM profession is able to influence some of the standards that are being developed as we move towards the electronic health record. The maintained viability really is all about the finances of the association. We do have formal committees that do the recruitment for the board, for the Council on Education. We also have Pinnacle Awards ceremonies every year for our members, and that would come under that portfolio as well. CHIMA, we do have what we call 3 domains of practice. Within the domains of practice really are our core competencies. The first, though, is what we call eHIM, so Electronic Health Information Management, and that's all about the work that we do currently and into the future around how will we transition our current members, so those members that are in the field, as well as our new students coming through the programs, how do we transition them from their traditional jobs to new jobs, new positions, new learnings for the electronic health record? And that, as I talk about challenges, I'll come back to this, because there is a challenge with, never mind keeping up with standards and legislation and all of the pan-Canadian initiatives in the paper world, but we're also dealing right now with the hybrid world, where most hospitals are partially paper and partially EHR, but nobody is yet there to the full electronic health record. And then what will that even look like for the fully electronic health record? Because really there is no full model out there. We are all developing this as we go along the way. So this is a huge challenge for this industry. And that would include not only just the health record, but we can also are very involved and want to ensure that the records management standards for telehealth are also taken into consideration. Our second domain is around data quality, and so a lot of the curriculum and a great deal of our members, as I said before, do code to the International Classification of Diseases. These are the members that for every hospital discharge in Canada, they would review every single record. In places like Ontario, that includes all the day surgery records, the emergency records, clinic records, to ensure that information is pulled out of those records, so they read the textual information that is turned into a classification that is developed by the World Health Organization, and that ICD codes then are forwarded on to the Canadian Institute for Health Information. So those of our members are very, very involved, much more with the biomedical sciences, anatomy, physiology, really having to understand what is in the patient record. Along with the coding is the data quality, the interpretation of that data and the quality of that data. And certainly in recent years, the CIHI and the Ministries of Health have been very concerned about the quality of the ICD-10 coding. Ontario especially, because the hospital's funding is attached to the case mix groups of the hospitals. Each code has a case mix group. Each case mix group has a resource intensity weight and a dollar attached to it. And while hospitals aren't fully funded on their case mix group, there is a component of their funding that is based on that. And there has been a worry that hospitals may be what they call upcoding, or CMG creep, we call it, where they're being a little creative with how they're coding records in order to get their cases more complex or into a more complexity level from the government. As well, when Canada moved into the ICD-10, about 5 or 6 years ago, I do believe we've been on 10 that long. Before that, we were on ICD-9. The World Health Organization brought out ICD-10, and so CIHI was really concerned about what was the quality of the coding and was it standardized across the country. When they looked at their national database, they saw great variability in some of the codes across the country. So, I mean, if we all assume that each hospital is treating patients the same way, why is the case mix groups very different amongst provinces and also amongst hospitals within provinces? So it has been, certainly in the last 5 years, the association has taken a great interest in the data quality portion to ensure that our members have the education and the opportunities to really have the time that they need to code these records appropriately. And then privacy. Privacy is inherent in a records management or health information management curriculum. We have always in the acute care been considered the custodian of the paper record, and right now also within the hybrid record. Where that will go in the future is, again, remains to be seen. We'll see what kind of models happen. But currently, we do consider ourselves the custodian of the record, and along with that goes all of the work and understanding the pan-Canadian and then the provincial legislation around the Personal Health Information Privacy Acts, and really ensuring that the 10 fair practice principles around privacy are adhered to. within the patient's record, again, whether it's paper, electronic, or within the hybrid. So who are certified health information management professionals? I touched a little bit on that, but they are graduates of recognized programs who have successfully challenged the exam. They're also active members, which means they must pay their dues on a yearly basis, and they must maintain 36 continuing professional education credits over a 3-year period. And the association, we have a model for auditing this, and we will be instituting that, I would say, within this next fiscal year. The requirements for education, most of the provinces would have at least one HIM program in the province. Some provinces, like Ontario, have 3 or 4. Those diploma programs are 2 years. The 4 programs in Quebec are actually 3-year programs, so basically the same curriculum and learning outcomes, but they teach them over a 3-year period. We have only 3 4-year degree programs in Canada, but we are in discussion with a few other universities to hopefully have the HIM or pure HIM taught within other degree programs. So the college and degree programs, they're taught similar learning outcomes, just at different levels. So there'll be more complexity at some of the for the outcomes based on whether we expect them to come up with a diploma or a degree. The learning outcomes, and again, goes back to our core competencies, the biomedical sciences, health information sciences, the whole privacy I talked about, health information analysis and presentation, technology and health information, the healthcare system in Canada, ethics and practice, general management skills, and then each year there is a clinical practicum for the students that they're expected to go out into the acute care or even to community health in order to get some practical experience. Up until this year, unfortunately, we have had to teach from the American textbooks. Canada hasn't had our own textbook, but just last month we finally received the Canadian HIM, Fundamentals in Health Information Management, which we have just produced. Any of you who have a real yen to understand what is all involved in health information management, a well-written text. The chapters are written by professionals and experts in their field, so it is a diverse group of authors who have written this book, but very well done. So past and current roles, some of these, there's a mixture here of the traditional roles. Certainly I have talked about coding classification specialists, so every hospital would have a number of people who code and abstract the records. That information goes to the Canadian Institute. Data analysis certainly is along the lines of somebody who would work in a program. Program management understands the case mix for a different program, helps them decide the types of cases that they will be doing and whether or not there is appropriate treatment modalities being captured when we're doing the coding. We have a lot of members now working in clinical trials. I'm not sure the number, but a lot of our members would be coding within cancer registries and other healthcare registries. We've had members being part of that wait time management project and also work in that realm now. Research, a lot of people are privacy officers. A lot of times it would be the management of the Health Records Department, but they do have the title of privacy officer. Project management, standards development, and what is very nice, the trend that we see right now is almost every Ministry of Health in Canada would now employ 1 or 2 HIM professionals. And we're finding those professionals within their data quality areas, again, ensuring that the clinical data has been submitted accordingly, and even offering education programs and feedback mechanisms to the coders in the hospital so that they are really monitoring the quality of that coding. Sales, we're seeing people move into sales as well. So the future role, there are so many evolutionary changes right now. The fact that we're moving so quickly towards the electronic health record, and that movement is in fits and starts. I mean, as hospitals have funding, they move things forward. You know, when the funding's not available, things are put on hold for a bit. The changes are different right across the country, and even though we have, and Canada is very lucky that we do have Canada Health Infoway, because that is a pan-Canadian approach to ensure that we will have standards built into the electronic health record when we're at that point. But in the meantime, every hospital, every region continues to move forward in purchasing their own computer systems and making their internal decisions on how they're going to move from the paper to the electronic health record. And there, as I said earlier, there's no roadmap for that. And so sometimes the field is way ahead of where the pan-Canadian strategy is, and a bit of a challenge for the people who actually work in the field. So whether it's the clinical staff, the clinicians, or even the people in the health information department, really making up the new world as they go along, as opposed to having a nice, clear roadmap on how to do that. I am going to talk a little bit about that a little bit later. I put physician impact in here because I felt that was important on the future role of the HIM. In the past, and just having written our textbook, one of the chapters that I did was certainly on the history of the profession. And it was very nice to read that when the physicians, and this is started in the U.S. early 20s, so 1920s, when hospitals basically were just infirmaries of patient care, there were no standards for records management or records keeping of any kind. And there is documented evidence of the physicians, so back in 1928 in Boston, where they asked records clerks to come to the table and help them develop a strategy for the management of what was documented in the records. And from that, there was a very strong and coordinated approach to develop it was a North American Records Management Association. So that was back in 1928. And then the American HIMA broke off into their own, as did CHIMA. It wasn't until actually during the war or shortly after the war in the mid-1940s that North America even started to talk to other countries, England and Australia, to see that they had a similar process. So it has always been that the health record management or the health information management professional worked very closely with the medical staff on records management standards. And in fact, most acute care hospitals would, the director of health records or their supervisors would be sitting on a medical records committee, ensuring that the hospital staff bylaws, rules and regulations that the Public Hospitals Act around records management is being adhered to. And in most cases, it would be the director of health records ensuring that the record, the legalities of the record, whether it's the completeness of the record or what the content of the record, what must be kept, what are critical documents, so on, that person would be working very closely with the medical staff. And so I put physician impact because as we move forward and we have the blurring of what is health information management, what is health informatics, and the fact that the physician is not always at the table, we're not really sure what we're going to look like at the end. And I want to just impress upon people that the records managers had a very strong linkage to the physicians and the clinicians in the paper world, and that we really need to articulate that in the electronic world as we move forward so that we're not reinventing, a wheel. And while we know that we don't just want to take the paper record and move it into electronic, that there has to be process changes, re-engineering changes, that the HIM professional has that past history and the linkages with the physicians to ensure that that moves forward. And then the future role in the development of electronic health record, again, that one is, I can't say that that our association and or our members have articulated well what our role could or should be. A lot of times our big excuse is that we're so buried in the paper and so buried in the minutia of the day-to-day operations, it's very difficult to think about how we would do it in the electronic world. And it has to be a true partnership. The HIM professional brings the processes, the functions. They understand what the legislation is, what are the critical components that need to make up a record. But it is the informaticians and the informatics folk that basically have the understanding of the pipes and the technology. Well, I don't think either one profession can do it on their own. And or they will, but it's going to take a lot longer than what the industry and or I would think our citizens would want us to take to do it. So I think it would behoove us all to ensure that we're working together. And I will talk a little bit about that when I talk about the long-range scenario planning that the association has done and how we see that rolling out over the next several months. So the health record, the fundamental purpose of the patient's record is continuity of patient care and a means of communication between the care provider and the care provider so that there is safe treatment of the patients. We are using the record for other purposes, and again, this is where I think there's a bit of a disconnect with the physicians, because the physician's purpose of the record is for continuity of patient care. The industry, the healthcare industry, sees other uses for the records that has evolved over the last several decades. Certainly the health system use, what we would call secondary use, and that is all about the collection of the data for CIHI. And Canada probably has one of the richest clinical databases in the world. So it is great that we have those databases, but it is data for secondary uses, and the physicians don't always record in the record for that purpose. And that's why the HIM professional then is having to interpret what's in the record in order to turn that into the codes that CIHI needs. Research, certainly a lot of research is getting done on the paper record, but we all know how much better that will be when it's fully computerized. The legal record, the health record is the legal record for the organization. It is their best defense on the care they made for the patient, and it's the patient's best defense that they were treated properly. And then certainly future health surveillance, and that is a very hot topic. We all know and understand that we need to collect more data for health surveillance, and that will be another purpose that we will have to fit into how the health record is developed into the future. So the electronic health record really is the health record plus. So it does support the traditional health record. However, we are going to be able to use it in the future for many more uses, whether that's healthcare collaboration, whether that's between hospitals, regions, governments, or even care providers. Chronic disease management, I think the figures are 40 to 70% of healthcare is spent on chronic diseases. And if we can capture a lot of new ways of collecting chronic disease management and have the patients utilize the health record in a different way to monitor their care, then certainly there may be lots of opportunity for cost savings. And then the consumer, what we call centric health solutions, and again, the patient portals, opportunities for patients to be much more involved in their care, monitoring their care, and this one actually also moves us towards the whole notion of the personal health record. And really in Canada, we're just starting at the national level to talk about a personal health record. And CHIMA always has had, we teach, personal health record and what that would mean, but there's been no real, effort put into this in Canada. The US, it's on their radar screen. Certainly Microsoft is thinking about what a personal health record. I read an article last week, Walmart is into the personal health record. kind of scares me on the privacy side, but we're moving forward in that way, so we have to, it's on the radar screen, we need to pay attention to it. The challenges, I did talk about the clinician, and not only is a clinician, I think, very much in tune with the health information, health record profession, but without their goodwill, their support, their buy-in, the eHealth achievements in the electronic health record will be much slower to get where we need it to be. So it doesn't matter whether it's Infoway or regional initiatives, whether it's Ontario or British Columbia for their eHealth strategy. If the physicians aren't buying in all the way along, it's going to be a little tougher sell in the long run. The clinical content of the record in the paper world has really been driven by what Public Hospitals Act says, what do the medical staff bylaws say, the nurses' disciplines, what they should be collecting. But in the future, with the opportunity of what we can collect, we'll have a bit of a different connotation to it. Certainly, one of the examples I have about only collecting information that is needed and to be thinking about the information would be the wait time initiative that we've just had in Ontario. The downstream effect of picking up one or two pieces of data is huge. It changed, how they collected data in the admitting department, at the point of care. Systems had to be changed throughout the hospitals. So every time we change the way we collect data or even delete data, there is a downstream effect for that. So people should be thinking about, not you can collect it because we can keep everything, but really, how is it going to be used and what are the downstreams going to be? Privacy, certainly CHIMA, we are advocates for the patients and for their privacy. However, we have very much embraced the 10 fair practice principles. We teach the collection of data and the uses of the data and the destruction and how long we keep the data. We have constructed our records management principles around the 10 fair practice principles. So that has been quite easy to do, and it's a very good match. We do not want to be the ones to say, we shouldn't, we need to put more controls on privacy. We only urge each association or each region to ensure that they're following the 10 fair practice principles and are only collecting what they should be collecting, and that there are controls in place for the security and the transmission of information. Just read an article last week or the week before. The Netherlands were way ahead on their electronic health record, and it just got totally scuttled because of physician and consumer pushback on the privacy issue, that they had not been involved and that they wanted to have public forums and know exactly what was going to be collected and how it was going to be used. So you can never say too much about ensuring all the stakeholders have a say in the privacy issue. So addressing the challenges, certainly standards is one. I just touched on that. In Canada, again, we're very lucky because we do have Canada Health Infoway. They do have the mandate and the funds to develop standards. Those of you, that's more, our members try to keep up and understand standards, and that's it. We will have a basic knowledge and understanding of standards, but we're not going to develop those technical standards. However, in order to ensure that the record, the compilation of the record is sound, safe, and legal, we do have to have an understanding. So whether it's the Health Level 7 standards, the DICOM for diagnostics, or LOINC for the labs, we do have to have an understanding of that. Canada Health Infoway have about 9 standards collaborative working groups right now. Each of those are to develop standards as we move towards the electronic health record. Those standards are linked to the International Standards Association. So it's not just Canada building standards on their own. It is an international initiative. Each country has taken a different standard to really understand it, develop it, write it up, and then get approvals at the international level, and then they implement in their country. But it is an incredible amount of work. Certainly, CHIMA encourages its members to sit on the working groups. The working groups are, you can monitor them. They hold web meetings, a lot of partnership meetings throughout the year. You can go online, you can go into their website and see what the position papers are on each of the standards. You can give input into those standards, lots of opportunity as we all move forward to be part of that. I talked a little bit about the security, privacy, and access. I'm not going to do more about that right now. I do want to talk about the challenge of the hybrid record, though. Huge challenges around that, the costs around that, and the risks for the system around that. And I don't think there's any hospital, I could be wrong, but I don't think there's any hospital in Canada that has a fully electronic health record. So most of them will be living in a paper, part electronic. And because our company, or our association, also has a consulting company, I find myself quite often brought in as a subject matter expert to help hospitals or regions to look at their migration from the paper to electronic health record. And the people in the field, again, the health records department usually and their clerical staff are just drowning in paper. A lot of most hospitals are trying to get their results and online, critical documents online, most of the dictated notes online. But again, if the physicians aren't using the online and they still want the paper record, then we're maintaining two systems as we move forward. And you can't always guarantee from a workload perspective that you're going to get every piece of critical information on both systems, on the paper, on the electronic. And so a lot of issues around that. And from my view, I see almost every hospital developing it their way. So there is not a standardized approach in Canada to take us through the hybrid record. Huge amount of dollars being spent at the local level as we migrate through this. So again, it's my little pitch, my sort of challenge to the industry that we need to do a better job of the hybrid record as we're transitioning through. Qualified professionals. I have been involved in a number of forums in the last 6 months, whether it's Canada Health Infoway or employers. There does seem to be a shortage of both health informatics and health information management professionals across the country. And again, there are some concerted efforts to at least look at this issue in order to see if it really is a problem. Some of the crucial roles then, the relationship to IT, HI, and HIM is very blurry. It has not been defined, and there's no one group's fault, but there is a huge opportunity, I guess, for us all to work together to define what it is we're doing currently. Because it's okay to say, we don't need the paper and we are going to decommission, the paper record in the health records department, but how are we going to get there? And that there is no model for the how to get there. There's models of what the future will look like, but no model to get there. So I think we all have a lot of opportunities to look at this. I've listed a few other areas where, and I think I've gone through them, where the role of the HIM will be in this transition. I do want to spend a few minutes, though, on the long-range scenario planning process. And CHIMA started this process probably back in about 2006. And I have to say we've got most of our support from the Ontario Ministry of Health, so I'd like to give them a bit of plug. The Data Quality Health Information Division, John McKinley and Staney Brown have had a very great interest in the health information professional, feel that they do have a role to play currently and into the future. And they did fund us to do a long-range scenario planning process. So a very formal, facilitated process. We interviewed, we did member surveys, we interviewed our members at different forums. We had opportunities for our members to give their feedback. That was the internal part of the process. The external process was for us to hold a number of think tanks where we brought in external stakeholders, ministry folks, the academic folks, to hear where they saw our profession 15 to 20 years from now. because we need to then do a transition strategy if that's what we felt needed to be. And those forums went very well. We had huge attendance. A lot of that information was synthesized, and then we had a facilitated process where upward of about 50 people who belonged to an association were actually called and had a 30 to 40-minute interview about very specific questions about where they thought this profession was going. There were 3 themes, I do believe, emerged that in 15, 20 years that the individual, the consumer, will be at the center of healthcare, that we needed to have collaboration, that no one profession is going to be able to figure this out. And we heard a lot of feedback. We don't understand, CHIMA, we don't understand COACH, we don't understand this group, we don't understand that group. Like, can't you people all come together in a coordinated effort to, help the industry understand what route we're taking? And then the other was the whole transformation and the pace of change. How are we going to deal with that, keep up with that? And from that, we have had several opportunities to take our themes and our messages to our internal and external stakeholders to say, okay, do you truly believe that is what the industry is saying? Is that what the industry needs? And certainly we heard over and over again that we do need to merge for strength and in order to move the platform forward. And that CHIMA should pick and occupy only those spots where our voice as CHIMA adds value. So where we're at with that is that we have a number of initiatives to collaborate, and whether we're working with COACH, the National Institute for Health Information, ITAC Health, many meetings with CIHI and Infoway, again to ensure that as we move forward, we have a coordinated strategy. Along with that, we've kept very close ties and collaboration with our own profession. So internationally, the International Federation of Health Record Organizations, which was established in 1968 by the World Health Organization, and that is because of the links to the International Classification of Diseases, Canada, US, and England being the founding members. And that Congress meets every 3 years. So we've been very keen to be on the same pathway as what's happening at the international. It's how we understand what is happening in the other continents and other countries as far as records management and coding and the electronic health record. Also, the American Health Information Management Association, we have very strong ties with that group. And in fact, we have a formal partnership with AHIMA. I think I said that CHIMA has around 5,000 members. AHIMA has about 55,000 members. So from a North American strategy, that's a huge voice for us to put our HIM profile in North America. So we do have collaboration across the borders. We are using the principles of adopt and adapt. So if the US has developed a standard, we would adopt and adapt it. Or if Canada has, they would do, as opposed to us both, reinventing wheels. We've also shared our long-range scenario planning. The U.S. is just finishing up their long-range scenario planning, and in fact, we have meetings, I do believe, in April to come together to look at that, to see how we might kind of exploit that, again, in a North American strategy. What we're working at an international level and a North American level is what does it mean for the electronic health record? How do we move into the eHIM world? Certainly keeping privacy, security, and confidentiality is on our radar screen, but certainly every country is going at that one about in a different way, even same as within Canada. So while we have some themes that are seem to match, they're not always congruent with each other. Clinical data management, and again, that's to ensure that the quality, the coding is upheld and that we're all in sync with each other. And then the health record information management education. We have continued to work with AHIMA, and we've come up with strategies promoting the migration from the paper to the electronic health record. None of us wants to live in the paper world anymore, so we are really encouraging that. Reinvent how institutional and personal health information and records are managed, and deliver measurable cost and quality results. One of the way we're doing that is, as you can see from this overhead, in about 2003, CHIMA began to organize their working groups around the transformation to the electronic health record. They now have 23 working groups that have added to their body of knowledge. I've given you a website for them because their work products are on their website. They've already finalized their work on speech recognition, computer-assisted coding, document management, things like that. In 2005, CHIMA then have merged, and we have representation on these working groups, and again, the adopt and adapt principle here in Canada, so that we have a North American strategy. From the academic perspective, both Canada and the United States have higher education programs dedicated to HIM. And we both have 2-year and then baccalaureate, and even in the U.S., some masters and PhDs in HIM. So we've completed and updated, we've done a crosswalk of our curriculums to ensure that we're teaching the same learning outcomes. We do have a reciprocal agreement with the U.S. If you're a graduate and certified in Canada, you can challenge their exam, and vice versa. CHIMA co-sponsors the Assembly on Education that is held for educators. That's held once a year, and we've developed a number of joint student recruitment material. So the primary goal around that is for Canada and or the U.S. to take each of our work and use it in our own settings. One of the works that has just happened is not in the last several months would be the HL7, the Electronic Health Record Functional Model, and that has been an international standard that has been trying to get voted on and approved for the last 2 or 3 years. And so when CHIMA and AHIMA joined forces, because that piece of work has been under the auspices of HL7 US, and the working group have been out of AHIMA, that ballot was turned down several times by the European countries. And just in the last 3 or 4 months, when we finally sat down together, finalized that piece of paper, it has been finally approved at the ISO level. So a lot of work now will have to come out of that as to how we'll look at the paper to the electronic. So really a bright future for our associations and opportunities on the HIM side to really, profile the skill sets for HIM. Some of I talked about those linkages with HIMA as far as our strategies. We do have close linkages with COACH, and again, that came out of our work with the long-range scenario planning. We now have regular meetings, our executive and their executive. We have COACH, ITAC Health, CIHI, and Canada Health Infoway have commissioned a sector study, and that'll be done by ITCT, which is Human Resources Canada, to do a formalized sector study on HI and HIM, so that, as I said earlier, we're not sure if we have enough qualified professionals to move forward for the electronic health record. Hopefully this study will give us some concrete results or evidence whether we need more, and then what would the roadmap be to do it. Strong linkages with Infoway, the National Institute of Health Information, especially what the CHIMA Board of Directors have made a final decision that they want a specialty for our members in health informatics. So of course we'll look to NIHI to help us to look at what does that look like. Certainly COACH does have a certificate in health informatics that they've adopted from the American HIMSS group. We're not sure if that fits for our members, so we'll look at that credential, but we'll also look at another specialty for informatics, which would then allow us to transition those of our members who want to be in that arena. So if they want to be in the health informatics arena, we will then develop courses. CHIMA won't. We'll ask the academic institutes to develop courses for those who are already working in the field to take their current skill sets, get upgraded in the understanding of the technology part, the informatics part, in order for them to have new roles. Quickly, I think I'm running out of time, some of the lessons learned. Certainly, I talked a little bit earlier about the changes, how quickly the changes are happening, and how does any of the professional groups keep up with that. It's very, very difficult. The shifting landscapes, and this changes on a monthly basis throughout the provinces. One year they're, when the hospital system is in silos. The next year they've been regionalized into 14 authorities, 28 authorities, and then the next month or year they're back to one authority, which means there is an incredible amount of change within the system, new management, new leaders, new government. Every time those changes happen, it's very, very hard to not only predict the future, but just to kind of live in the current world. I raised earlier the personal health record. I don't know what that's going to mean, but I see that as a lesson learned and a challenge in that we haven't really thought about the personal health record, and should we be doing that now as opposed to at the end of the path. Certainly, what CHIMA heard during the long-range scenario planning process, I had my eyes wide open. Not everybody loves, everybody, but we heard a lot of good things, and we heard, though, some very hard truths. And we know that we have to bring our members along too, because it doesn't matter what industry you're in, there is resistance to change. And a lot of our own members are resistant to the change. But if you really look at and listen to some of these seminars, we know we're on the brink of the full electronic health record. So every traditional job that a health records department has today will change within 5 to 10 years. So you can't coast until you retire. A lot of people would love to do that, but you can't. So, you have to really be in the know, understand it, and be heard, have your voice heard, not come along kicking and screaming. And also, a big lesson for me is we need resources. We don't have the resources to do the proper research and develop the new skill sets that our current 5,000 members have. They need to transition into a new type of worker. Where are those resources going to come from and the dollars to do that? Never mind the new graduates and how we're going to upgrade the learning outcomes for the new students. So my conclusion is that HIM is a crucial part, and we play a real crucial role in the development, the deployment, maintenance, and evolution of electronic health information systems. And I leave you with a list of resources. We have a number of professional practice briefs that we brought out probably over the last 6 months, but again, to get something on the table for our members to be working in the real world. And then I mentioned about the fundamentals of I just want to go back here. I guess I thought I had a list of the professional practice briefs on there, but I don't. So what I'll give you is the www.echima.ca, where we have all of those professional practice briefs listed for you, and we certainly encourage you to use them. So thank you. You've been a wonderful audience, those of you that I can see, and I hope that I've brought some clarity to the HIM role, and certainly be happy to take any questions.
All right, thank you so much. I think we already have a question from one of the webcast people. I don't know who that might be.
Hi, from Dominic. His first question: what needs to be done by CHIMA, HIMSS, and eHealth departments and institutions in order to make it possible for HIMSs to play their appropriate role on the eHealth team? Would you like to hear that again?
It's a very multi-faceted, complex question. It's not just one thing they have to do. I think some of the challenges that I raised is that there is some onus on the health information management, the individual, to articulate their role. We can't just sit and do our work and hope that somebody's going to notice the good work we've been doing for the last 65 years and that they intuitively know, oh, this is how they should be, what the new skills they need in order for them to be a new type of worker. That is going to have to come from the individuals, and also from CHIMA. And I truly believe CHIMA has been doing a good job for the last 5 years. We are knocking at everybody's door. We are on everybody's radar screen. But we can't be talking out of both sides of our mouths. We need to have our members be interested and ready for change. The professional practice briefs are a very good first step to put those on the table. So first you have to get yourself, and if you have to knock on doors, you must be on the electronic health records committees or the medical records committee. If you've lost ground on those, you need to get those back, because if you're not even at the table, you're not going to be heard. Once you're at the table, you can use the professional practice briefs to articulate what our role needs to be. But you also need to be taking some education in the background in order for you to also have some knowledge of what it is that you're saying. For instance, the boot camp that's coming up, that was specifically designed for health information management practitioners in order for them to have just a basic understanding of the eHealth world and the health informatics part of that, just so they can talk the language. We're not expecting them to be knowledgeable, but they need to be able to talk the language when they're on those teams. And I'm not saying it's going to be easy. From our consulting arm, we have to push in there and continue to articulate the role in the paper world, but we have to give be able to give senior management a level of comfort that we know how to move into the electronic world. And some of that is through those professional practice briefs would give you some body of knowledge on how to do that. Hopefully I've answered that.
Okay, a second question from Dominic. What are the key barriers that stand in the way of HIMs fulfilling an appropriate role on the eHealth team?
One of them would be our lack of understanding. Probably in Canada, I might get a little wrapped on this, and I expect emails after this presentation, but there's probably only a couple of dozen HIMs who truly understand the eHealth or health informatics world. The rest of them, I don't know if they're waiting for this to just, be bestowed upon them, but there has to be some way for HIMs who want to transition to get some learning so that they can be part of the eHealth team. Some of our members will continue to code. Those who code, they'll be doing it differently, but there probably will be a strategy in order for crosswalks from ICD-10 to the SNOMED or what other new nomenclatures or terminologies. And so that one is a little clearer. You won't be doing your job the same way, but there might be a clearer path to get that group there. But for the group that truly want to do their traditional records management in the eHealth world, they have a lot of learning to do. So that would be certainly one strategy that comes to mind, that someone's not going to hand it to you. You have to go out there and get educated in that.
I have a question, and or maybe a couple of questions. You talked about how so many of the hospitals are developing their own migration path, and that there's no standard approach. How do we get a standard approach, and who drives that?
Again, very complex question, because it is the merging of different worlds. And in the past, the Director of Health Records and the Health Records HIM professional has developed the policies and procedures in the paper world. And whether or not we're not stepping forward soon enough or not getting involved where we need to be, there is a huge, disconnect for, that migration. And there are a lot of examples. If I went on to websites in England and Australia, there are a lot of papers, there are a lot of books out of the US about the how to do it. So whether our members in the field are not keeping up to date, I'm not really sure. I certainly talk to a lot of directors of health records that really know where they're going, and they're at the forefront of leading the electronic health records. One of our members in Alberta has just been named the vice president for the entire region, health region in Alberta, and she has the entire, gamut of all of the components of health information management. So we see different models sprouting up, and I think it depends on who's leading, who has the solution that they can sell to the medical staff and to administration. Those are the ones who are being heard right now. Whether or not they're right will be remain to be seen, but there has to be a strategy where we have some standards, some policies, some procedures for very basic records management functions.
So I assume from that then you see a role that Canada Health Infoway plays?
That's hard to say. I have had these discussions with Canada Health Infoway. They are strategic investors. They're not going to be developing policies and procedures. They're developing technical standards, the pipes, the infrastructure, those health information access layers. They're not doing the content part. They're assuming that the content part will be done, at the local levels. And it is, but it's just that because there is no straightforward pathway or it's not written out in clear English, everybody's doing their own thing.
So a little bit of it could be not invented here?
True. That's true. So,
any questions from we've got at least two guests from Conestoga College. Do you have a question that you can pose to our guest speaker?
I do have a question. I was wondering, in the context of the evolution of the HIM professional, when I went once to emergency room, besides the nurse who took care of us, in the triage, there was this other person that was entering clinical and other information into a system. Who was that person, and could that have been a HIM professional or evolved?
Well, it could. It depends on the level. If it's just the demographic information, it will probably be an emergency, clerical staff. But hospitals are, again, the role of HIM is expanding into what we're calling concurrent coding, where a lot of hospitals, especially, I find it most to be the teaching hospitals, are taking the health information manager who codes and have them write on the unit, or they belong to the program. They're attached, and are paid by and work for the medicine program or the surgical program or the emergency program. And those folks are bringing this whole records management, the standards to ensure a complete comprehensive record by time of discharge. So they're collecting every bit of clinical information. It might say to the physician, the patient, he's been admitted and he has a comorbid condition that he's admitted to that will affect his length of stay, and you've not recorded that. Do you think, we could get that added now? And if the patient runs into a complication in the hospital, usually the HIM person right now, if you're not doing concurrent coding, you don't find that out until you've read the record after discharge. But if you can get it at the time, again, that will affect the patient's length of stay. That means that you're going to have more comprehensive coding, you're going to pick up more coding, and then the record usually is going to be complete by the time the patient's ready to go.
It's with my idea that, other people's findings that clinicians do not particularly like to code, but we could have people that know how to understand the information in the health record that could do that.
Yeah.
So,
yeah.
Yep.
Thank you. I'm the student from Conestoga College. And I have a question. You mentioned about this decision support part. You said now they are kind of move away from this profession, or like, can you elaborate a little bit more about this decision support part? Like,
I think you just didn't quite understand the question. I'm sorry.
So you mentioned about this health record department in different hospitals, and then you talk about they have different roles. For example, managing the records, do transcription, coding, and then you also mentioned about the decision support role. And then you said that will be a separate story, kind of moving direction. Can
True.
you elaborate a little bit
At
on
the,
that?
as our board of directors makes decisions around specialties for HIMs, and so this is moving into new roles, so specializing in something other than general records management or coding. One of the roles, one of the specialties will be decision support or an information analyst. And that role, we see a lot, almost every acute care hospital has a decision support department, and that would be made up of somebody from finance, probably somebody from quality, and then ideally a health information management professional that understands how the data has been inputted and can analyze it. So we absolutely, those of our members that work for ministries of health would very much be in a role also of understanding the data decision support. So that is a role that we see our university graduates would go into. It's not always the role that the college student is looking for. They're looking more for traditional coding and maybe quantitative analysis, or certainly not, and I mean not transcription, but not always thinking about that other step towards actually analyzing the data for planning purposes for the hospital or for financial purposes for the hospital. So.
Thank you so much for your presentation. I have a question. For example, when you talk about the process of going from paper-based health records to the electronic-based health record, and there is this intermediate state where to some percentage we have a hybrid situation. It looks to me like health informatics professionals, and we know that health informatics is really such a rich area where people can specialize in a variety of different areas. It looks to me that really it's very difficult to be health informatics professional and know everything that is necessary to know in order to support this process from the point of view of health information management part. So my first question is, for such kind of projects, how do you have any suggestions how it's possible for organizations that are trying to move either from the point of view of acute health organizations, or, for example, from the point of view of regions or provinces, when people move from paper-based to electronic-based, how they have to put together teams so that to ensure that health information management piece is really addressed? And this is my first question. And I will hold.
Let me deal with that one. Well, again, I'm not trying to push all the traditional roles, because I know we have to move into new models. But in the current world, what has worked best for the paper record, and while I understand that it wasn't the best, there were things that could have been done better, it still has worked for us, and the right piece of paper is usually pulled at the right time for the patient's care. But right now, the team, the Health Record Committee, is made up of a combination of physicians and nurses and OT, PT, so other clinicians, as well as the Quality Assurance Department, the Risk Department, the Privacy Department, because they all truly understand their full roles and make up the full components of the record for patient care, the legal record, research, and those other secondary uses. So I think, why wouldn't that work in the hybrid and the electronic world? Because they are the right people. Why are we trying to reinvent, new workers without trying to transition those who understand the processes now. So and again, I mean, I think what I was trying to say earlier, it's a combination. Some HIMs and some directors are very much at the forefront and have been able to articulate their role, but others who, you know, and traditionally, and I don't want to malign our members, but because I'm one myself, but we traditionally are very introverted, you know, a little more reserved, and have never really put ourselves out there. And that's a skill set that we're also going to have to use, or the system is going to get reinvented. You know, so if we want our records management strategies that we do know how to transition some of these strategies, and if we want to be heard, probably we're going to have to do a lot more pushing and actually have something to put on the table that proves that we do know what we're talking about.
Okay, thank you. And the second question is, let's say that exactly what you said now, that people who are moving on that path, they realize that they need some kind of professionals with the health information management background on their teams. What would be your recommendation about how they should look for a specific set of skills and knowledge that would satisfy their needs? The options, just to contact you, or to, like, does your organization have suggestions? What is the set of skills and knowledge these people have to have in order to help? Yeah.
Well, certainly we do have a council on education as well as a professional practice council that would be able to, you know, say to a potential employer, this is the skills they should have. We also would want them, though, to meet with their management from health information or health records department to be given that opportunity. There is no one profession that has all the pieces, so you're just not going to throw out the baby with the bath, or the, you know, the baby with the water. There is an opportunity for hospitals and regions to invest in those health information management professionals that have really probably 70% of the core skill sets to help their hospitals move to electronic health record, to invest in upskilling them, you know, whether that's taking courses in health informatics and or matching them with the informaticians and health informatics folks to bring out the best in both of those two professions. To me, that is the quickest way for Canada to get where it needs to be, as opposed to having 2 or 3 separate streams that are kind of looking to be, you know, at odds with each other. So that would be my, but I would start at your health records department. If you feel that that person is not, you know, is pushing back, you know, that's going to be an issue, you know, and would have to be dealt with from that perspective. Yeah.
Wonderful. Thank you so much.
You're welcome.
I understand we have a question from the web.
What time frame are you looking for when you mention the health informatics specialty for those who are currently HIM professionals?
Okay. Well, because we finally, after 18 months, have a mandate from the board of directors, and that just came this week. So that is such good news. I'm so excited about that. That means we can put the business plan together. And we already have it was a long-range scenario planning task team that is now turned into a strategic planning task team. And that task team has already looked at criteria for deciding what specialty will we tackle first. We have choices. Certainly the HI is one that is high on a list because a huge amount of our members who really are records management need to transition into that arena. But we do have our coders that could go coding specialties, or they could go decision support. They could be doing jobs like that. So we'll be using this criteria to determine what ones we should do first. We'll take 1 or 2, develop a model. We are not going to develop these on our own. We will go to, say, the National Institute of Health Informatics, so we'll go to the academics and or work with Coach, to say what is the fastest route to get our members who want to do health informatics, you know, trained up. If it's standards, that we have people who want to really concentrate on standards for the electronic health record, we've already had discussions with Canada Health Infoway, and we would probably partner with them for them to deliver the content on that. If it's coding specialties, we've already talked with CIHI, and we would assume that they would teach that, but then, and so those of our members who want to get into that arena would go that route. So the time frame, I would think within 6 months we'll have our first model. This is high on the association's priority too, and especially to ensure our rightful place in the eHealth environment. We see HI being one of our first.
From Dominic. Thanks, Gail. Great presentation.
Oh.
And how did you get into this field and why?
Have we got time? By mistake. I think most of us, are never always where we think we're going to start. So I started out as a transcriptionist, and I always say that maybe I would like to do that because it's so much easier to do transcription. But, I have done education my entire life. Have never stopped going, thank goodness for, a Western mostly by continuing education programs. But then certainly when I got into the records management was because I did manage a transcription department. So, of course, it was an easy move then to take the HIM program and move from there. How did I get to the organization is another whole story, still shaking my head on that. I was quite happy in London Health Sciences Centre running a clinical program, but I've loved it. I mean, the opportunities and certainly our board of directors and our members, for the most part, are great. And, I'm very pleased to be able to help them with a strategy or a pathway for our future.
I have, over lunchtime, we talked a bit about the human resources that are required as we move into this e-health world, and the difficulties that we're all struggling with in terms of just figuring out who's doing what, and what we would like to have is some, at least at Stats Canada, some means of being able to label people as HIMs or HIMs or HI people. How do we get there?
We did have a short conversation about that at lunch, and certainly one of the other major projects that CHIMA has been involved in over the last several years is to get a national occupation code for HIM professionals. Right now, we're in national occupation codes by our job titles, and we find quite a lot of our members, the jobs they do are sitting in a clerical classification code, which is not at all good for our profession, because when colleges or the students are going from high school to college or university, we're not even on their, a lot of the jobs aren't even on their radar screen because they don't fall in to a national occupation or employment code that they would even be looking at. So we have a whole issue around identity just because of some of our jobs being in the wrong national occupation codes. We do have a temporary code where health information management sits. It's within a broad management code. It is not within a specific. We have actually met with Human Resources Canada and Stats Canada within the last 5 or 6 months. We had been lobbying for a special code just for health information management, and then even introduced the notion of, and health informaticians could be in there, but we have been told pretty emphatically that there's no new occupation codes being introduced in Canada, so the best we can hope for is to move us out of any clerical codes and into. But I agree, I think when we go to do this sector study, that we will find it very difficult to know how many HIMs and how many informaticians or how many even nursing informatics people are within the field. It's going to be very difficult for us to do planning, especially for whether it's student recruitment and or job recruitment. It's going to be difficult for the next several years.
Right. Any other questions? Further questions? Oh, there's one here. Good.
Thank you. My question is that does the CHIMA, it's like a Canadian organization, and I was wondering, does it model it after any other countries, like in EU or in Australia, where they might have already implemented eHealth, and then, you were mentioning that different countries have different models. Does Canada look to other countries for guidance?
Well, yes, CHIMA is probably one of the very first countries to have an organized program. We are only one of a very few countries that actually have a college. Even the U.S. does not have a college. They recognize programs within the education system, but they are not classified as a college. Australia, Korea have colleges. England, Great Britain has a college. We meet, as I said, with the International Federation. We meet every 3 years, and we do update each other on how we're moving each of our own agendas forward. CHIMA actually has one of our members sits on the Executive Council for the International Federation, so we're very much these days in tune. The last Congress was last year in Korea, and it was very interesting for us. Korea is very far advanced with the electronic health record, and in fact, their Congress, there were 2 streams, HI, HIM, and when I asked the questions about what has been the role of the HIM, they were at the table all the way. We were taken out for a lovely VIP dinner, and their Ministry of Health said that they have the HI here and the HIM there. Just the question that Yuri asked a little bit earlier, they are doing it together. They see the absolute skill sets of both of those professions getting the right model at the end.
Well, I want to thank everybody for attending our session today, and thank you so much, Gail, for coming and talking to us. You are such a good advocate for your profession.
Thank you.
I mean, it's just wonderful.
Thank you.
So we have a little bit of a gift for you.
Oh, thank you.
To thank you for coming today.
Great, thank you.
And I hope you all will come back. I must be close to somebody's mic. I hope you all will come back next month, either by the web or video broadcast from OTN in person. Please join us on April 22nd when we have our next